Honorable Chair Dr. Zerger, ladies and gentlemen, at the outset I must say that the poster which I was watching sitting there was absolutely captivating and fantastic. So thank you organizers for the same. Now coming to my topic, these are my financial disclosures. Have received payment in the course of disease. And if you could do that, it really makes a very meaningful impact in reducing the burden of complications. No matter down the line, even if you lose the control, the benefit that you continue to reap in terms of microvascular and macrovascular risk reduction is absolutely phenomenal. And this is particularly important in terms of macrovascular risk reduction, where publication of few of the mega trials like Accord, Advance and VADT have actually cast a pall of gloom, a sense of pessimism in the minds of physicians that treating diabetes is not a very good idea because it will not make a meaningful impact in reducing the macrovascular complications. But look at the profile of the patients who were recruited in Accord, Advance and VADT. These were the patients who have spent 8 to 12 years following diagnosis and have been left with very poor glycemic control, what we call a bad metabolic memory. And it really makes good sense to follow the trials like the DCCT, the UKPDS, and the Steno, which recruited patients at the time of diagnosis, achieved good glycemic control and tried to maintain a good A1C around 7%, and then you could make an impact even 20 to 30 years down the line to reduce the macrovascular complications as well. So it's very important to address these issues in this context. Effective and early glycemic control will help you achieve your target of reducing the complications. Now, what are the tools available to the clinicians? We all are very familiar to use the lifestyle modification, and there is absolutely no controversy that along with lifestyle modification, metformin is the numero uno drug to be used in management of type 2 diabetes. But when we come to the stage 2, we have got a plethora of options of 6 drugs today recommended by ADA ESD guideline. Now this is not surprising, and I think it's very sensible because the chairperson talked about individualizing the management of type 2 diabetes. And considering the phenotypic heterogeneity of type 2 diabetic subjects, and also very important, the number of pathophysiological mechanisms which are responsible for type 2 diabetes, we do need this plethora of choice in selecting the second-line agent to combine with metformin. Now today in this symposium, we are going to focus on GLP-1 receptor agonist, and the reason is very simple. Last 3 or 4 decades of research have actually brought this molecule in a situation where we are using this molecule as a second line, third line, and in fact in the entire disease continuum of type 2 diabetes. The story started with some very seminal work from the elegant lab of Professor Creutzfeldt in Germany. You know, Michael Nock, Uris Meyer, all these great diabetologists and endocrinologists have worked in this lab. And this Entero-Insular axis concept, when you take your food, the substrate itself stimulates the islet cells. It can stimulate through the vagal transmission. But most important, what we learned is the endocrinal route of stimulating the islet cells. And the first hormone that was identified was the GIP, but then it was the GLP-1 which set the stage for its therapeutic potential. And why was it? If you look at the comparison between the GLP-1 and the GIP, you could clearly see that the GLP-1 gives you most the early and the late phase insulin response, which GIP fails to do. And therefore, if you really want to harness the therapeutic potential of a GLP-1 based therapy, you have to use GLP-1 and not the GIP. And what is very elegant about this molecule is that it reduces the blood sugar in a glucose-dependent manner. At higher levels of blood glucose, you have got very smart secretion of insulin, but when the blood sugars come down to normal level, there is a reduction in the secretion of insulin. And that's called glucose-dependent stimulation of the beta cell, and at the same time, glucose-dependent suppression of the alpha cell. And that is so very elegant to manage patients with type 2 diabetes. Now, all we know very clearly is that in type 2 diabetes, we have got the reduced beta cell mass and beta cell function, and that will impair the maximum insulin secretory capacity. Now, this is very important to understand that when you have reduced insulin secretory capacity, it will not only cause hyperglycemia, but it will also blunt the usual incretin response. And what is incretin response? You should have a brisker response to oral glucose as compared to intravenous glucose. But here what you see, the intravenous response is very well maintained, but the oral glucose response is attenuated in type 2 diabetes. And then it combines along with the reduced insulin secretory capacity to perpetuate the process of hyperglycemia. And then in turn, it also reduces the secretion of the GLP-1. Whether GIP is important or not, but one thing is very sure, that this milieu is going to downregulate the GIP receptor and create a situation of GIP resistance, which is further going to add to the glycemic burden of these patients. And therefore, incretin-based treatment are there to stay and are going to be extremely useful to patients of type 2 diabetes. When you also look at the incretin effect, it directly correlates with the fasting hyperglycemia. You can see in normal people and first-degree relatives, you have got very nice incretin response, whereas with increasing and worsening glycemia, you can see a reduction in the incretin effect. And this is so very important and demands that incretin should be used for management of type 2 diabetes. There are a number of unmet needs in type 2 diabetes management, of which I am sure all of us agree that inexorable decline in beta cell function is a most challenging issue that we need to address. If you use an incretin-based molecule, you can improve the beta cell neogenesis and replication, and you can make a big impact in reducing the beta cell apoptosis, and that in turn is going to improve the beta cell mass and function, and over time it's going to help you not only in achieving but maintaining a glycemic control over a prolonged period of time. But there are a number of doubting Thomases all over the world which will tell you that these animal model data are rubbish. They are of no use and we don't believe on them. So ladies and gentlemen, if you don't believe on them, please look at the hardcore clinical data. This is the 4 years follow-up Exenatide data, and it's amazing to see that the HbA1c, which dropped in the early part at the end of 1 year, at the end of 4 years' time, it's still maintained at 6.9%. We all know very well that in humans, it's extremely difficult to assess the beta cell mass and beta cell function. And I think durability, sustainability of the control is a wonderful reflection of the beta cell mass and function. And therefore, if you have got a sustained reduction in the A1C and fasting plasma glucose, that will give you a very huge percentage of people who are well within the targets of HbA1c and certainly going to make an impact in reducing the vascular complications. The second important issue that needs to be addressed in the management is the issue of hypoglycemia. Whether you talk of type 1 diabetes, type 2 diabetes, we have got a huge problem at hand. And this is the UKPDS data that whether you talk of major episodes of hypoglycemia, any episode of hypoglycemia, if you embark upon intensive treatment, you are going to pay a price for that. And that was also reflected in Advanced Accord and BADT, where you showed that intensive treatment led to a huge increase in the incidence of hypoglycemia. Whether that attributed to increased mortality in Accord study is a different question. That may be debatable. But the fact that more hypoglycemia was reported is not debatable. But this is a very interesting study. I would like to draw your attention to this very important sub-study which was done from the Accord group of patients. Now, whether you treat your patient in the standard way or in the intensive way, if you are at the target, if you are doing well with glycemic control, the incidence of hypoglycemia is less. That's a contradiction. We normally think that if we reduce the glycemic burden with a drug, Lower the blood sugar, higher the risk of hypoglycemia. The fact is just the opposite. If you have got a select group of patients who have got uncontrolled blood sugar, they are likely to have more hypoglycemia. So ladies and gentlemen, it stands to reason that controlling blood sugar is not a bad idea. What is bad idea is to use agents which create problems with them. We have to find the right patient, the right agent, and then good glycemic control will not create any problem at all in the management paradigm. If we look at the incidence of hypoglycemia with insulin and sulfonylureas, they are absolutely not acceptable. That we know for sure. Metformin and TZD is reasonable. But when we look at this pattern of incretin behavior, then this is something very interesting. In a type 2 diabetic patient, you know that the insulin sensitivity, which should have been around 90 milligrams per deciliter here, is shifted here. And then you want to overcome, suppose you use a molecule like sulfonylurea, what do? You increase the insulin secretion when the blood sugar is high, and you also increase the insulin secretion when the blood sugar has dropped down to normal. And that is responsible for a glucose-independent mechanism of insulin secretion, and that is inherently causing a danger of hypoglycemia. On the other hand, if you use a GLP-1 based treatment, this secretion of insulin doesn't go upwards like this, but there is a leftward shift. That means you have increased secretion only until the blood sugar levels are high, and then you stop secreting insulin when the blood sugar levels are normal. And this is called glucose-dependent stimulation of insulin secretion, and this will not lead to hypoglycemia. And this is not very surprising because we know that GLP-1 based treatment act from a different receptor. They do not follow this potassium ATP channel, and therefore there is an independent mechanism of action which is responsible for its glucose-dependent mechanism. Another important issue to discuss is the weight gain. Our chairman alluded to this fact that weight gain is an inherent problem in management of type 2 diabetes. And every single study done on a GLP-1 based treatment you can see here leads to a decreased energy intake, and that is translated into very impressive reduction in the body weight when you used any GLP-1 based treatment. Whether you use an Exenatide, whether you use a weekly Exenatide or a liraglutide, all the GLP-1 based treatment are going to cause very impressive weight loss of anything varying from 2.53 kilograms sometimes to huge weight loss of even 15 kilograms. And the interesting thing is that when you lose weight, you don't lose the lean body mass. You lose the visceral fat. This study which was done with the DEXA scan has clearly showed that the weight loss with GLP-1 based treatment is not of lean body mass, but it comes primarily from the visceral fat, and we all know that visceral fat is a powerhouse of production of inflammatory cytokines, and therefore it's again going to be extremely beneficial to the patients of type 2 diabetes. And therefore we can actually look at the pleiotropic effects of GLP-1 after secretion in the intestine. They make this wonderful effect on the pancreas that I have already alluded to. They reduce the gastric emptying. GLP-1 receptors are situated on cardiomyocytes and vascular endothelium, and therefore putatively they should reduce the risk of cardiovascular complications. Appetite, hunger, satiety, weight reduction, very important outcome. And then you have got very impressive effect in reducing the hepatic glucose output, and to some extent addressing the issue of insulin resistance, both at the level of adipose tissue and at the level of muscles. But to exert this pleiotropic effect, you need substantial amount of GLP-1. Physiological concentrations are not going to do good enough to achieve these pleiotropic effects. You need to have the pharmacological concentration of GLP-1, and that is what is important in clinical practice. And therefore, compared to DPP-4 inhibitors, GLP-1 analogs are going to be more effective in exerting the pleiotropic effects of a GLP-1 based treatment. Beyond the glycemic control, there are a number of extra glycemic effects of GLP-1 acting on heart, gut, brain and fat. I have already briefly alluded to these facts, and there are direct mechanisms, indirect mechanisms. Time will not permit me to go into these details, but you all know that there are a number of studies which have been done which have shown favorable outcomes on all these individual organ systems. Their effect on the brown adipocyte, white adipocyte, many of you must have known that by now GLP-1 analog liraglutide 3 milligram is now approved for use as an anti-obesity agent as well. So we have got these wonderful effects of GLP-1 based treatment, and in 3 to 4 years' time, when the cardiovascular outcome studies are published, then we will know for sure that whether this is the molecule which can have a favorable impact in reducing the cardiovascular complications. These extra pancreatic effects have led to its use in obesity management. A lot of studies are going to be done in Alzheimer's disease, Huntington's disease, and a decrease in the blood pressure is already demonstrated in the clinical development program of these molecules. And a reduction in the systolic blood pressure is a very important surrogate marker for improved cardiovascular outcome. And across the board, in every single study, again you can see here, if you use a GLP-1 based treatment, you make a very impressive reduction in systolic blood pressure. And we also know the putative mechanisms through which the GLP-1 based treatment leads to a reduction in the blood pressure, whether we talk of increased natriuresis or we talk in terms of inducing vasodilatation. All these mechanisms are very well understood. That brings us to the family of GLP-1 based treatment, and there are two backbones that we are talking about. We are talking about a human GLP-1 backbone, of which we have got once daily molecule liraglutide, and now the weekly molecules albiglutide and dulaglutide. And then we have the Exendin 4 backbone. The first molecule in that sector was the Exenatide, used twice a day, occasionally once a day. And then we had the weekly Exenatide, Bidurian, and now the lixisenatide. So we have got a plethora of GLP-1 analogs available. They are all approved by different regulatory agencies. And the fundamental difference amongst all these molecules translates from their half-life. Shorter the half-life, more frequently the injection has to be given, but because of these long half-lives, we have got number of once-weekly molecule, starting from dulaglutide, albiglutide, and long-acting exenatide. All these are now available for commercial uses. For clinicians like me and you, what is important is to select the right patient for a GLP-1 based treatment. Now obviously a patient who doesn't have a good glycemic control is already taking 1 or 2 anti-diabetic medications orally, and the A1C is hovering between 7.5 to 9.5. You can ask me why not less than 7.5 and why not more than 9.5? In less than 7.5, I would go for a triple or even a quadruple oral drug combination, and in more than 9.5, I would be much more comfortable to use insulin along with any combination. So between 7.5 to 9.5, I would position this molecule, which is going to give you the further benefit of reduction in the body weight, no problem with hypoglycemia. And most important, when you make a change in the regimen of treatment, you are struggling with the lifestyle pattern. I'm sure anybody would be quite happy to have an injection every Sunday and to have a good glycemic control with extra benefit of weight loss and reduction in the systolic blood pressure. So GLP-1 based treatment should be used early in the course of the disease. If 1 or 2 oral drugs have failed, you should not be waiting for eternity to make a change in the treatment regimen, because we talked about the beauty of good glycemic control in the early part of the natural history of type 2 diabetes, and this will give you a smart reduction in A1C, no risk of hypoglycemia, weight loss, possibly benefit in terms of CV risk factors, and fantastic improvement in the adherence because of once weekly administration. Now if you compare with insulin, what happens to GLP-1? Insulin has got the risk of hypoglycemia, weight gain. Hypoglycemia risk in fact is very high. There are certain other side effects that we are talking about. You need daily titration of insulin, and you need frequent monitoring of your patient, which is not only cumbersome but quite expensive to do. And the cost, of course, is less as compared to a GLP-1 based treatment. But with GLP-1, everything is on the better side except for the gastrointestinal side effect, and that too is obviated to a considerable extent by using the weekly molecule as compared to the daily molecule. We look at this comparative data between a GLP-1 receptor agonist vis-a-vis insulin. And on every single front you can see better reduction of HbA1c, better weight loss, but with the fasting plasma glucose, insulin, a basal insulin, scores over a GLP-1. So it also sets the stage for combining a GLP-1 with a basal insulin if you have got an A1C of more than 9.5%. And less hypoglycemia, of course, and some extra side effects in terms of gastrointestinal side effect. Now, what is the quantum of reduction of HbA1c? As we move from the Exenatide twice daily, we were talking about 0.7 to 1% reduction in HbA1c. Then we had the Dulaglutide given once daily, and anything from 1% to 1.5% reduction in HbA1c, which is an extremely robust result. And then we move on to weekly Exenatide, it improves further, 1.5 even up to 1.9%. And now we have got 1.5 milligram of Dulaglutide, again giving you an A1C reduction as high as 1.51%. So the A1C reduction is extremely, very, very impressive. But one thing is important, please don't compare these molecules, because the baseline A1C in these studies were very different. They were not head-to-head studies, and therefore this point has to be carefully noted. Now this is a direct study comparing Dulaglutide with insulin glargine, and you can see here both at the end of 52 weeks and at the end of 78 weeks, very impressive reduction in A1C as compared to insulin glargine, almost double, and very impressive weight loss, and that is persistent at the end of 78 weeks as well. So very impressive result. A GLP-1 analog scores over insulin glargine clearly in terms of A1C reduction, weight loss, and without incurring the risk of hypoglycemia that is so very welcome in the treatment paradigm. So 1.5 milligram Dulaglutide clearly scores over insulin glargine in this particular study. And I was part of this study, so I can really put my heart out on this because I was involved for almost 2 years in this particular study. When you look at the weight change with the GLP-1 based treatment, again, you can see here very impressive weight reduction, whether you talk of any of these studies, and in comparison to all the other molecules that we have used in clinical practice, the weight reduction is very impressive with both doses, 1.5 and even 0.75 milligrams of Dulaglutide. But 1.5 milligram is one which is most important from clinical perspective. So ladies and gentlemen, I would like to wind up my talk by telling you that when you are treating a patient of type 2 diabetes, these unfortunate patients are not only taking anti-diabetic medications. We know that diabetes is a metabolic disease and you have got number of comorbidities. And you have got a long prescription, 5, 6, 7, 8 medications. And therefore you would like to reduce the number of medications and frequency of administration. So a molecule with a very long duration of action like infrequent administration once weekly is going to make a tremendous impact in terms of improving the patient's adherence. This will reduce the complexity because you can have fixed dose combinations, decreased frequency, weight loss or weight neutrality, and particularly this glucose-dependent effect which obviates the issue of hypoglycemia is extremely important in terms of clinical outcome. So, GLP-1 receptor agonist can be used and should be used in the entire continuum of type 2 diabetes management. I would position this molecule as the first injectable after the failure of 1 or 2 or 3 oral drug combinations. They are very effective in reducing the glycemic parameter HbA1c. They reduce the body weight, improve the cardiovascular biomarkers, and are associated with no or minimal risk of hypoglycemia. Number of these molecules are now available for your disposal, and now it has become a very well-established class of anti-diabetic agent. I would like to thank all of you for a very patient attention. Thank you very much.